you've just heard a beautiful description of new work based on what we are learning about what's going on at the cellular level in the brain. What I'm going to talk about is a rather different approach, and that's saying, well, we know that there are cells that die in Huntington's disease, and we've heard a lot about that today, particularly in the caudate and putamen. What happens if we try to put those cells back? Can we repair the damage that's been done in the brain? Can we reconnect the circuits? So what I'm going to talk about today is, first of all, is transplantation a reasonable and rational approach in Huntington's disease? Why Huntington's disease is a particularly good paradigm for looking at transplantation, and why it has lessons that may be learned for neurodegeneration more widely. What we've achieved so far using fetal donor cells, so these are ones taken directly from the fetal brain, and what do we need to achieve in order to develop stem cells as a donor source for cell replacement therapy. So I'm going to draw a distinction between cells which are taken directly from the fetal brain, so they're not expanded in culture, they're taken and put straight into the patient, and cells that are allowed to proliferate in the lab. So Sarah has given you a lot about this today. We know that there is predominantly loss of medium spiny neurons, and this is just showing you a picture of a medium spiny neuron in the caudate and putamen. Now, although ultimately it may be that cell replacement therapies are able to replace diseases where we've got quite widespread neural loss, at this stage of development, it's very important that we are able to look at this in diseases where we've got very focal cell loss. And that's the first reason why Huntington's disease is a very good paradigm for this. Because early on we have very focal loss, and we have a particular cell type that's lost. So we know we need to replace medium spiny neurons. So that gives us a very clear target. In addition to that, we've got very good animal models for Huntington's disease, so that helps us a lot in terms of the preclinical work. And again, this is something Sarah mentioned earlier. We can diagnose Huntington's in life, and that's terribly powerful when we're doing clinical studies. And to draw a comparison with Parkinson's disease, where this sort of work first started, in Parkinson's disease, we're making largely a clinical diagnosis. So some of the patients in those studies down the road turned out not to have Parkinson's disease, and obviously that reduces the power of your study. And Huntington's disease is also, I would argue, a better test of circuit reconstruction. Now, what do I mean by that? I think this is quite important, so I'm going to just spend a moment or two going through this in more detail. This is just a schematic showing you in blue the caudate and putamen and the striatum, and here in green the globus pallidus, and here's the substantia nigra. So these are all bits of the basal ganglia, and they all act together to allow us to move, think, and behave normally. Now, in Parkinson's disease, you may well be aware that we lose dopamine cells from the substantia nigra. So these cells project all the way up to the striatum. So in Parkinson's disease, these are the cells that we're trying to replace. Now, when these cells are developing in the fetal brain, they're able to make this journey right up to this area, and that's where they need to innovate. That's their target. But when you're putting them back into the adult brain, there are lots of signals that are designed to stop that sort of thing happening. And so the cells are not able to make that journey from the substantia nigra back to the striatum. So what we have to do in Parkinson's disease, and this is what has been done in both animal studies and clinical trials, is put the new cells back directly into the striatum. So in other words, they're being placed ectopically. And what this means is that although they innovate and they release dopamine, they're not subject to their normal connections. Now, in Huntington's disease, the situation is quite different. We're losing cells in the striatum. We can put the cells back directly into the striatum. So we can really test whether it's possible to reconnect a circuit in the brain in a relatively normal fashion. So does it work? So this is a slide from Steve Dunnett, and this is summarising around about 3 decades worth of Steve's work. And apologies to Steve, I'm going to summarise it in less than a minute. But basically, what he's shown is that if you take fetal neurons from the developing striatum, so these are developing medium spiny neurons, they know they've got to become medium spiny neurons. They've received all the signals to become that sort of cell. If you put those back into an animal model of Huntington's disease, they can survive, and they express DARP32, which is a marker of medium spiny neurons. So what this is telling us is that they can become striatal-like tissue in the adult brain. Furthermore, if we look anatomically, we can show that these cells connect up, so that looks very promising. And if we look electrically, we can show that they appear to connect up electrically as well. So this is evidence that those cells that we put back in are able to reconnect circuits, at least at some level. But of course, the proof of the pudding is whether you get better function from the animal. And indeed, there's quite a lot of work that shows that if you do this in the right way, you can improve the way the animal functions. I should say it doesn't put the animal completely back to normal. So going back to Bernhard's point about a cure, it's not a cure, but it does produce significant benefit. So this was the stage that had been reached by the end of the 1990s. And at this stage, there was enough preclinically for people to want to start to look in patients. And towards the end of the 1990s and the early 200s, a number of small trials of neural transplantation in patients with Huntington's disease, quite advanced Huntington's disease, which showed that, largely speaking, it's a safe procedure. And of course, that's quite an important thing to show, because what we're talking about here is taking cells, doing a neurosurgical procedure, a needle into the brain, and injecting those cells into the striatum. The other thing that you'll notice here is that these numbers are quite small, and that this work is quite slow in its progression. And again, harking back to what Bernhard said, this is a really good demonstration of just how patient we have to be to get the answers out. And to sort of try and explain why this work is slow, and this is the UK safety and efficacy trial, which was a multi-centre study. And just to give you a flavour of this, to set up the fetal tissue collection, which of course we had to have full ethical permission, technically was quite difficult to do. This alone took about 3 to 4 years. The patients, because these are small trials, and at this stage in the game it wouldn't be justifiable to start transplanting large numbers of patients, these patients have to be followed for a long time in great detail. And so to get through a number of patients can take a considerable amount of time. It took around about a year just to transplant 4 patients unilaterally with fetal tissue, and that was in part due to the scarcity of fetal tissue. So just to summarise quite a lot of data from the literature, we know that we've got post-mortem studies which show that fetal tissue can survive in the brain. This is a study from Freeman's group showing striatal-like differentiation in a patient who died, not related to the surgery, but 18 months post-grafting. And this group has also published evidence of surviving grafts 10 years post-operatively. It has to be said that these grafts show some evidence of attack from the immune system, and so that's giving us a bit of further information, which is that although the brain is supposedly subject to immune privilege, it isn't a complete immune privilege. And so it's quite likely that patients undergoing transplants will need to be on immunotherapy. But the evidence that the grafts may be producing some sort of functional benefit came from the group of Anne-Catherine Bashir-Levy. And this is in just 5 patients. And they had quite a nice natural experiment here. So they transplanted 5 patients with fetal tissue. In 2 of those patients, the graft either didn't survive or was rejected. And in the 2 patients who then effectively had sham lesions, so didn't have a surviving graft, they continued to deteriorate. So this is a cognitive scale. A high score is good, a low score is bad, and these are years along the bottom. I'm looking at this one here. And so you can see the 2 patients who had no grafts continued to decline over time. The 3 patients in whom there was good graft survival showed stabilization of cognitive parameters over quite a long period of time. They also showed some stabilization or improvements in movement. So although this is far from proof, and it doesn't tell us how robust this sort of effect may be, what it does do is show us that if we get the parameters right, we've got proof of concept. We can make transplants work in Huntington's disease individuals. And this is just to let you know that there has been a larger trial by the French group and the French network, which has now closed. This is a trial of effectively 60 patients, 30 having had the graft initially, and the control group were grafted 18 months later. And this is currently being analysed. So hopefully over the next year or so, we'll have a little bit more information on the clinical front. So you may have noticed that the UK study was published in 2002, the safety study, and that there have been no other UK publications since. And there's a very good reason for that. And that is that in about 2003, there was an EU directive that tissue manipulated for human use had to be manipulated under GMP, good manufacturing practice, conditions. And what this meant in reality was that as a group, we've had to raise money, build a whole GMP suite, and undergo accreditation for that. As we were novices in that process, that's taken us some time, but we've now had the HTA license granted, so the clinical phase of planning the next cohort of patients in the UK is about to start, although that will probably take another 1 to 2 years before that trial can be reinitiated. So just to summarise so far, what this shows is that if you use cells that know that they are to become medium spiny neurons, you take them at the right developmental stage and you put them back in the brain with a bit of immunotherapy, then you can, if you're lucky, get improvement in the patient. So it's fair to say that there's quite a lot more to do in Huntington's disease using primary fetal tissue to make that a robust finding. But at the same time, we have to also be aware that primary fetal tissue is not going to be a long-term solution. And the reasons for that are, first of all, supply and demand. It's really difficult to get fetal tissue of the right quality to produce a functional graft. And the second reason is that fetal tissue has to, like a lot of organ donations, has to be transplanted within a period of time. And that's a few days. we can hold it for a few days under certain conditions, and then it has to be transplanted. And that gives us a very short period of time in which to do pathological screening and other quality control measures on this tissue. So we desperately need a renewable source of tissue, and the most likely renewable source of tissue is stem cells. So I'm going to now just say a little bit about stem cells and what their place might be in cell transplantation. But before I do, I just want to highlight one other aspect of fetal tissue, which is that over the last few years, we have found that rather than collecting fetal tissue from surgical terminations of pregnancies, we've been able to collect from medical terminations. And to cut a long story short, that has increased the amount of viable tissue that we have been able to put towards the clinical programs. Although, so this is a halfway house, in other words. This will make the rest of the fetal tissue work possible, but it, again, isn't a long-term answer. So, stem cells. So I think the first thing to say is that the word stem cells covers a huge array of cells, and basically when we talk about stem cells, we're talking about cells which can proliferate in culture, but which can then be differentiated into particular cell types. And we can get those from embryonic stem cells, we can collect stem cells from the fetal brain, or even potentially from the adult brain. So there are lots of starting sources for stem cells, but they all have one thing in common, which is that they're very undifferentiated. They don't know by default what they need to become. And so they have to be instructed to become a certain type of cell. And that's not an easy thing to do. So at the moment, that is probably the biggest challenge for stem cells in terms of cell therapy. I mean, what we want the stem cells to do is very much what we want them to do in terms of, we want them to do a job very much like the primary fetal tissue. We want to be able to put them in the brain, we want them to survive and differentiate into medium spiny neurons, and we want them to connect up the circuitry. So the big challenge is getting stem cells to differentiate into medium spiny neurons. The way we can go about trying to do this is to try and expose them to some of the signals that are present during normal development. And we don't know what all those signals are at the moment, but if we use some of the signals that we do know about, we can start to push stem cells a little bit towards a medium spiny neuron phenotype. And this is just showing you a study that we did in the lab. This is a rat brain, and you can see here this darker area is the graft. And when we look on high power, this hasn't projected terribly well, but the brown cells are DARP positive, so remembering that DARP is a marker of medium spiny neurons, and the blue is a neuronal marker. So we do see a few cells which look like they may be medium spiny neurons, but we really aren't seeing very many. So this wouldn't be enough to have a hope of producing a functional effect. So one of the things that we've tried to do is to go back to square one and try and explore what are the signals that are present in developing medium spiny neurons. And so we've looked at what all the genes may be that are upregulated as medium spiny neurons are born. And we've done this in the mouse brain, so we can look at the mouse brain over the period that we know medium spiny neurons are being generated. When we do that, we find a number of genes that are upregulated and a number of genes that are downregulated. And I'm not going to go into that in great detail, but just to illustrate how this sort of approach works, one of those genes called FOXP1 is probably the most upregulated gene by quite a long way over that period of time. And we're quite interested in the function of FOXP1 now. It may turn out to be an important gene in terms of allowing cells to develop into medium spiny neurons. We've shown that it's upregulated during development, and FOXP1 then stays on right the way through to adulthood. So it's present even in adult medium spiny neurons. And if we look in the adult brain, we can see that all DARP cells are also labelled with FOXP1. So this doesn't tell us for certain that it's important, but it's a bit of a clue. It disappears when we do a quinolinic acid lesion of the brain. So this is a lesion that gets rid of medium spiny neurons. If we get rid of those, we also get rid of FOXP1. If we take medium spiny neurons out of the developing brain and put them in a dish, they continue to express FOXP1, and we can show that it co-labels with DARP32. And if we take those cells and make a transplant out of them, we can also show upregulation of FOXP1 in the transplant. But probably the most convincing bit of evidence so far is if we use a transgenic animal which has been made to not have FOXP1. So this is an animal in which FOXP1 is knocked down genetically. And if we make transplants out of the fetal brain of those animals, we can show that they don't express DARP32. So if we're just looking at these sections here, this is a FOXP1 knockdown, and we can see there's an absence of FOXP1 as we'd expect, but we have got a graft there, we have got cells, but they're not expressing DARP32. So this suggests that in this type of cell, where we've lost FOXP1, we don't get medium spiny neurons. So there's still quite a long way to go to even be sure that FOXP1 is important in medium spiny neuron differentiation, but this is really just illustrating just how long it takes even to isolate one factor that may be valuable in terms of what we're hoping to achieve. So I'm aware we're quite short of time, so I'm just going to very briefly highlight one other issue, which is that I've talked about making medium spiny neurons, and clearly that's absolutely critical to having a graft that functions. But we also have to be very aware that at the current time, we don't really know how primary grafts work. We don't really know how a graft improves function in the brain. We don't know that we just need medium spiny neurons. And there's some work that suggests that actually medium spiny neurons are critical, but we may also need some other types of neurons in there. We might need some interneurons, and we might need to pay attention to other cells such as astrocytes, which are non-neuronal cells. So it's really very complex, and what this means is that we have to not only pay attention to driving stem cells towards the right sort of phenotype, but we have to also go back and ask some quite detailed questions about how grafts are functioning in the brain. So to summarise, the messages I want to put across are that so far the work done in animals and in clinical trials suggests that fetal transplants can improve function if we get it right. And at the moment, we don't know all the factors to getting it right. And some of the factors that we haven't considered at all yet are there certain patients who will benefit more from a graft than others? We need to be able to find a renewable source of cells, and that's likely to be stem cells. But before they're going to be of any use whatsoever clinically, we have to be able to drive them towards a medium spiny neuron phenotype. And we need to exploit the primary grafts, the fetal grafts, better to understand what it is that makes a successful graft. So I'll leave it there. Thank you.